Good morning, everyone. My name is Gretchen Miller, and I'm a Community Education Coordinator for Boulder Community Health. I'd like to welcome you today to our lecture on lowering your blood pressure. Before we begin, I need to make a few announcements. Please take a moment to silence your cell phones so we don't interrupt the lecture. Appreciate that. Also, we appreciate it if you would remember to fill out the yellow evaluation forms we gave you in the packet when you checked in. We look at these very closely when we're planning future lectures. Is that better? Okay. Also, I want to let you know that BCH has moved to a new electronic health record called EPIC. EPIC provides quicker access to patient information, which means BCH doctors and nurses can coordinate your care better. One of the big benefits of EPIC is a great online portal that's really popular with patients. The portal lets you do things like view test results, message your care team, and much more. We call the portal My BCH. You can access it from your computer or get an app for your phone. You can sign up the next time you're at BCH for patient care service, or you can register today using the My BCH website or smartphone apps listed on the flyer that you received during registration. Finally, I'd like to go over the format for the lecture today. The lecture portion will last for about 45 minutes, and afterwards we'll take about 15 minutes to answer general questions. Please limit your questions to general ones that the whole group can benefit from hearing. Thank you. On behalf of Boulder Community Health, it's my pleasure to introduce today's speaker, Dr. Yogitha Potini. Dr. Yogitha Potini is board certified in internal medicine. She received her medical degree from Southern Illinois University School of Medicine in Springfield, Illinois, and she completed residency training at St. Vincent Hospital in Indianapolis, Indiana. Dr. Potini enjoys practicing the full spectrum of general internal medicine with special interests in preventative care, hypertension, diabetes, and women's health. She has expertise in managing patients with multiple chronic health conditions, and she enjoys partnering with her patients to meet their health care goals and providing the best possible evidence-based care. Dr. Potini just recently joined Internal Medicine Associates of Boulder, so please help me give a warm welcome today to Dr. Potini. Thank you.
Thank you, Gretchen. So as she said, my name is Yogitha Potini. I'm an internal medicine physician at Internal Medicine Associates of Boulder, and we're going to talk today about blood pressure and hypertension. So what is hypertension? High blood pressure, hypertension are synonymous. So if you're told you have hypertension, that means you have high blood pressure. Blood pressure is the force of blood circulating through your arteries, and we measure it in your peripheral arteries. And a normal blood pressure is 120/80. Elevated blood pressure or pre-hypertension would be considered 121 to 129 for the top number, over 81 to 89 for the bottom number. And hypertension is anything 130 or above, over 90 or above. Now, this might be different than what some of you are used to or have heard in the past. Previous guidelines did tell us that hypertension or high blood pressure was actually 140/90 for a general population. And actually, previous guidelines told us that if you are 60 or over, you would qualify as hypertensive at 150/90. These guidelines are outdated as in the past few years with new research that's come out. Most recently, the SPRINT trial came out, which showed that there are lower rates of fatal and non-fatal cardiovascular events and death from any cause if we control blood pressure a little bit tighter. And those guidelines are what I have shown here, with hypertension being anything 130 and above. The one thing to keep in mind is when we control blood pressure more tightly like this, there are chances that you might have some adverse events from too tightly controlled blood pressure when your blood pressure gets a little low. That's always something to keep in mind and keep in discussions with your doctor. That data, however, does not apply to diabetics. There's a separate trial done, the ACCORD trial, specifically targeting diabetics, which tells us that the top number, systolic blood pressure goals of 130 or less, are adequate. All right. So this is just an infographic I took from the American Heart Association to kind of give you an idea of how hypertension impacts us as a nation. About 1 in 3 Americans, that's okay. 1 in 3 Americans have high blood pressure, and that can contribute to about 1,000 deaths per day. That's not necessarily hypertension alone, but any other conditions that your high blood pressure might contribute to, such as you can see, heart attack, stroke, or chronic heart failure. Hypertension costs us about $51 billion per year in annual healthcare dollars. And about $48 billion of that is in direct medical expenses. Other things are, like missed work days, things like that. So as I said, about 1 in 3 Americans do have hypertension. That comes out to about 75 million people, and only about 54% of those people are actually well controlled. Additionally, only about 1 in 5 U.S. adults or 1 in 5 U.S. adults do not know that they have hypertension, so 1 in 5 people are walking around with high blood pressure without even knowing it. Of those 75 million people who do have hypertension, 7 out of 10 of those people do take medications for it. So a lot of people. This is a map that I got from the Behavioral Risk Factor Surveillance System, BRFSS. It's a data source that provides a lot of the most up-to-date current trends in the US. So as you can see, so Colorado, not too bad comparatively. 24 to 27% of people have hypertension. I came from the Midwest, where there was a lot more. About 1 in 3 people have pre-hypertension, which is that range of 121 to 129 over 81 to 89. And hypertension is a primary contributor to the cause of death in about 400,000 people. Each year, that's about 1,100 per day. So that's just to give you an idea of kind of how it's affecting us here in Colorado versus everywhere else. So to kind of talk a little bit about how blood pressure works, I won't go into too much detail. It's a lot of physics and things like that. But as I was saying, your blood pressure is measured 2 numbers, systolic blood pressure over diastolic blood pressure. Your systolic pressure is the pressure in your blood vessels when your heart is beating or contracting, and the diastolic pressure is the pressure in your blood vessels when your heart is relaxing. Blood pressure is calculated by your cardiac output, or how much blood your heart is pumping out with each beat, times the peripheral resistance, or essentially the elasticity of your peripheral arteries. That'll give you your mean arterial pressure or your blood pressure. Other things that play a role, your kidneys, the filtration system can sense the blood pressure, as well as hormones that are relayed to the kidneys. That's the angiotensin, renin, aldosterone system. It's a complicated network between your brain, other receptors throughout your body, and your kidneys, as well as nervous system receptors as well, that can sense, that type of fight or flight system, which can sometimes increase your blood pressure as well. So this is just to show you how blood pressure can affect your body. As you can see, it does affect pretty much all major systems: your heart, your vision, your brain, kidneys. You can even have sexual dysfunction. So things to keep in mind. All right. So risks of high blood pressure. Hypertension is known as the silent killer. The reason for that is because you can't really see or feel the effects of high blood pressure until the damage is done. So a lot of people say, well, I feel fine, I don't need to take medication, but these are all the reasons that you do need to take the medication, because having high blood pressure can have a lasting effect on your body overall. As you saw before, it can contribute to heart disease, heart attacks, congestive heart failure, kidney disease, stroke, eye disease. And I know a lot of people talk about having really high blood pressure and you're going to stroke out. But more commonly, we see chronic kidney disease, congestive heart failure, those types of things from high blood pressure. I'll just touch on the sexual dysfunction a little bit now, as I don't really have another slide on it later, but essentially men can have issues with erectile dysfunction, not getting enough blood flow to the genitals. For everybody, you can have a loss of libido and interest. So that's kind of how it affects that. All right, so to talk about heart disease a little bit, we'll talk about heart attacks. So with high blood pressure, that can cause hardening of the arteries and a buildup of plaque, which can cause blockages. So essentially, when your blood pressure is really high, you can lose some of that elasticity, so your arteries stiffen. That can then lead to decreased blood flow to the heart. Symptoms of heart attack are chest pain, shortness of breath, those typical things you might think of, and it can, of course, lead to death. And there's lots of kind of steps in between. Ideally, you would, of course, have intervention before you got to that step. But it's something to keep in mind that high blood pressure can lead to that type of coronary artery disease or contribute to that. And that can contribute to building up plaque in the arteries. With congestive heart failure, high blood pressure is actually one of the most common causes to have this type of heart failure. What it is you basically have a decreased function of the heart, or your heart doesn't pump as efficiently or effectively. That can lead to a lot of different issues. You might feel shortness of breath because you have a backup of fluid, swelling in your legs, fatigued, that type of thing. And with continued congestive heart failure, especially if you don't get treated or not on the right medications, that can also lead to death because you're just not pumping the blood forward to perfuse the rest of your body. All right, kidney disease. So chronic kidney disease, hypertension and diabetes are probably some of the more common causes of this. And what it is you have decreased in your kidneys, again, efficiency and effectiveness to filter your blood, so you can get a buildup of fluid, different salts, toxins in your body, that if they build up can be catastrophic. Additionally, because as I mentioned before, your kidneys are involved in regulation of your blood pressure, with chronic kidney disease, you can sometimes see worsening of your blood pressure control. With time, chronic kidney disease can eventually lead to dialysis versus a kidney transplant if it's not well controlled and if it continues to progress. So that ideally, we would want to catch it early to prevent that type of sequelae. So stroke, again, this is the same kind of thing. You can have ischemic strokes, or strokes that are caused by blockages, versus hemorrhagic strokes, or strokes that are bleeding in the brain. How this happens is For the ischemic stroke, it's similar to heart attack. You have a hardening of the arteries, buildup of plaque, which blocks blood flow to parts of the brain. For hemorrhagic strokes, you can see, especially with like really high blood pressures, your arteries, the walls of your arteries get weakened and sometimes can burst, leading to bleeding in the brain. Symptoms of stroke: weakness, paralysis, changes in your speech, difficulty walking. You may have heard of the acronym FAST: face drooping, arm weakness, speech slurring, time to call 911. Those are general symptoms of stroke. And, how you recover from that is very variable. So you can have some catastrophic results from stroke, and some people can do better. It's very variable. So eye disease. Here I have a picture of a normal retina, and this is a retina that has succumbed to hypertensive disease. So with chronic poorly controlled hypertension, this causes thickening of the vessels in the retina, which affects how you see. It decreases blood flow to the retina, which can decrease your vision, and in some cases cause vision loss, as well as severe elevation in blood pressure can cause swelling of the nerves in the eye, and that can also lead to permanent irreversible vision loss. And you can see here other problems from hypertension. You can get areas of infarct or ischemia like here, there. You can get retinal hemorrhages, things like that. So it can affect your vision. All right. So what causes high blood pressure? There are things we can control and things we can't control. The things we can't control are genetics. If you have a genetic predisposition for high blood pressure, that's not really something you can control. Your age, we all, are victims to time and age, and your blood pressure does increase with age, so at some point, most people might develop hypertension, whether that's at age 40 or age 90, can be changed based on some of the other factors we'll talk about. Race, you can't change that, and evidence does show that African Americans are more likely to develop hypertension and at an earlier age than Caucasian, Asian Americans, and Hispanic Americans. It's not something you can change, but something to be aware of. Sex, you can't change, but typically women and men have about an equal chance of developing hypertension. Things you can control. So your diet, how you eat, how much salt are you intaking, that can affect your blood pressure. Your weight, if you're obese, overweight or obese, that can also affect your blood pressure. Fitness, how active you are. So even if you're not overweight, but if you're inactive, that can still affect your blood pressure. Alcohol consumption, how much you're drinking each day. Smoking affects your blood pressure, so if you stop smoking, that will reduce it. And just by having diabetes, that can also increase your risk for hypertension. Certain medications can raise your blood pressure. Some herbal over-the-counter supplements, cold medications, oral contraceptives, NSAIDs like ibuprofen, naproxen, and some antidepressants as well can have an effect on your blood pressure, as well as street drugs such as cocaine or methamphetamines can also raise your blood pressure. All right, so how do we diagnose hypertension? So everybody ages 18 or older should be screened for hypertension. And this screening is really just when you go to your primary care doctor, your physician, they check your blood pressure when you're there, and that's how you're screened for hypertension. You can also check your blood pressure at home. There are home blood pressure monitors you can purchase at any pharmacy, or typically a lot of pharmacies have blood pressure measuring machines there. You can just go in and check every now and then if you are so inclined, just to keep track of your blood pressure. We also have ambulatory blood pressure monitors. We don't use these as frequently because typically we can diagnose hypertension based on in-office screening in addition to your own home monitoring. But if, for some reason, whenever you check your blood pressure at home, it's always normal, but you're coming into the office and that's the only time we notice that it's high, that would be an appropriate time to try an ambulatory blood pressure monitor. It's a device that you wear that keeps track of your blood pressure, which can help us in diagnosing white coat hypertension. But typically we don't use those, but it is available. And then if you are checking your blood pressure at home, always keep a log. At minimum, just write them down, but ideally you would also write down what time of day you took your blood pressure as well. Okay. So, causes of blood pressure, we kind of talked about risk factors, and 95 to 98% of hypertension is primary or essential hypertension. That's what most people have, and that's what all those risk factors kind of contribute to. There are secondary causes of hypertension. They're pretty rare, so much so that we don't screen for them unless there's a reason to. If you are diagnosed with hypertension under the age of 30, we would screen you for these. If you've been controlled for years and years and years and all of a sudden have difficulty controlling your blood pressure jumps up, then we might consider screening you for certain causes of secondary hypertension. If your blood pressure is drug resistant, you're on so many different medications and you just can't get your blood pressure controlled, and we don't have other explanations for that, we might screen you for secondary causes. Sleep apnea can also contribute to hypertension. So if you have some symptoms of sleep apnea or you just are hypertensive, that might be something you want to be screened for. Other causes of secondary hypertension are I'll just briefly review them: renal artery stenosis, some medications, and then hormonal issues. And then just briefly to touch on sleep apnea, things to be looking out for are if you snore at night, excessively tired during the day, someone observes you stop breathing during your sleep, high blood pressure, and then your weight, age, gender, and neck circumference can kind of be screening tools for sleep apnea. Okay, so this is an infographic I got from the American Heart Association, how to measure your blood pressure. This is in-office monitoring, but I just wanted to use it to illustrate how you should be checking your blood pressure at home. You should be sitting in a chair with your feet flat on the ground, ideally a flat-backed chair with support, so a dining room chair or something similar to that. And you should be sitting back straight, supported, feet flat on the ground, and just sit there for about 5 minutes or so to kind of relax, calm down, and then check your blood pressure then. The cuff should be, your arm should be on a table, relax. The cuff should be about at the height of your heart before you check your blood pressure. And then you can, of course, write down the day, the time, and what your measurements were that day. There's that. All right, so lifestyle modifications. A lot of these are going to address sort of those risk factors that I touched on earlier: diet, exercise, weight loss, decreasing your alcohol consumption. It doesn't have to be complete omission of alcohol, and then of course stopping smoking. All right, this is a chart that I wanted to show you all. It's a little bit wordy and hard to read, but it does sort of show you that just by lifestyle modifications alone, you can make a significant impact on your blood pressure. For example, with weight loss, for every 1 kilogram or about 2.2 pounds in weight reduction, you can decrease your blood pressure by about 5 points, the top number usually. And most importantly, a healthy diet. If you change your diet to like a DASH type diet, you can reduce your blood pressure by 11 points, that top number. And then adding into that a decrease in salt intake, another 5 to 6 points. Exercise, about 5 points. And then decreasing your alcohol can affect up to a decrease in 4 points. And this says, women less than or equal to 1 drink a day, men less than or equal to 2 drinks a day. It can be less than that as well, but that's just the guideline that they used here for this chart. All right, so to talk about the DASH diet a little bit, because as I showed you, if you follow that diet, you could reduce your systolic blood pressure by 10 to 11 points. I just wanted to touch on it. So DASH stands for Dietary Approaches to Stop Hypertension. There are 2 levels. There's the standard, which is you limit yourself to 2,300 milligrams of sodium a day, and then the low sodium version, which is 1,500 milligrams of sodium a day. In order to see the most benefit, you would follow the lower sodium one, which is the 1,500 milligrams. A typical American diet is about 3,400 milligrams of sodium a day to kind of give you an idea of how much we're asking you to reduce your salt intake. So the DASH diet limits total fat, saturated and trans fats, focuses on whole grains, fruits and vegetables, low-fat dairy, those types of things. The typical things you might think of a healthy diet. If you looked on, the Department of Health and Human Services, myplate.org or whatever, they might talk about that type of diet. I also wanted to touch on ways that you can decrease salt in your diet. Try to avoid canned foods, and if you do use canned foods, even if they're low sodium canned foods, still rinse whatever's in the can to try and get as much of that out as you can. Don't add salt to your food, especially if you're at a restaurant, don't put salt on your food while you're cooking. Try not to use salt. There are other ways to flavor your food that don't use salt. A lot of people will use garlic salt, maybe just try garlic powder instead of the salt version. There is actually a product like Mrs. Dash that was based off of this DASH diet to flavor your food without using salt. Not that I'm recommending you get that particular product, but just as a point of information. Ready-to-eat cereals actually have a lot of sodium in them, as do packaged breads, particularly white breads. So those are things that you might not think of, oh, this is healthy, but they actually are high in sodium. So you always want to be looking at food labels when you're out buying your groceries. And of course, deli meat as well is high in sodium. So exercise, another way to improve your blood pressure and just overall health. So the Department of Health and Human Services recommends 150 minutes of moderate aerobic activity per week or 75 minutes of vigorous aerobic activity per week. Moderate aerobic exercise are things like brisk walking, swimming, mowing the lawn, something you can do and still converse with people, and they're not completely out of breath. Vigorous exercise are more things like running, aerobic dancing, those things where you're can only get out 1 or 2 words at a time and are more focused on your activity. Other things that can help with your blood pressure, actually strength training twice a week, anything like weight machines, body weight exercises. They even list rock climbing as a way to do that. That might get you some aerobic activity as well. Reduced sitting time, so even if you comply with that 150 minutes a week, if that's, if you're doing that but then still sitting most of your day, that's not as beneficial. So you want to try to sit less often. So maybe every 2 hours, take a 10-minute break, get up, walk around your office, whatever it is, just so that you're not sitting all day. I think everybody nowadays is guilty of that, myself included. So trying to reduce that sitting time can also have an effect on your blood pressure. Another thing that's popular nowadays are high intensity intervals. So if you say I don't have time to exercise 30 minutes 5 days a week, even just doing small spurts of higher intensity physical activity, more of that vigorous aerobic activity, can also be beneficial. And the other point I wanted to add is that you can get more benefit if you increase that 150 minutes to 300 minutes a week. Okay, so I wanted to review medications in brief. And just as a caveat, this is not an exhaustive or complete list. This is just a review for educational purposes. You might be on the medication I don't mention or what have you. You always want to talk about these things with your physician and, with shared decision making, come up with whatever the right plan is for you, especially in regards to medications. But typically, the first-line medications for hypertension are ACE inhibitors or ARBs. Those are related. Calcium channel blockers or diuretics. So ACE inhibitors, examples of these are medications like lisinopril, enalapril, ramipril. They typically are preferred first-line medications, especially if you have diabetes, because they can be kidney protective. Side effects include cough or angioedema. If you have angioedema after taking an ACE inhibitor, you should not ever be on it again because you are at risk for airway compromise. The angiotensin II receptor blockers, or ARBs, are related to ACE inhibitors. They work in a similar fashion. These are medications like losartan, valsartan, irbesartan. And again, typically we would try an ACE inhibitor first, and if, say, you have cough with that, we might try you on an ARB. They tend to have a little bit less cough side effect, and see how you do. And when you're on these medications, you do need to have yearly blood work just so that we can monitor your kidney function. Diuretics are another first-line medication. These are things like hydrochlorothiazide and chlorothalidone. The side effects for these, you can have some metabolic derangements in terms of your sodium, potassium levels, things with kidney filtering, so you also need blood work monitoring for this as well. You may notice an increased need to urinate, as they are diuretics, so they're getting some water off of you, as well as if you've been on them long term, they may precipitate a gout attack. That's not that common, but something to be aware of. Let's see. So calcium channel blockers are the other first-line medication typically. These are medications like amlodipine and nicardipine. Side effects most commonly are lower extremity swelling. You might also get palpitations. If you have significant heart disease, like multiple heart attacks, really bad heart failure, you may want to avoid these medications, but again, that's something to discuss with your doctor. There are other calcium channel blockers such as diltiazem and verapamil. Typically, we would use those for also rate control if you have like atrial fibrillation or something like that, but they can also have an effect on blood pressure, but typically the amlodipine and nicardipine we would use first if it's for blood pressure alone. So what about beta blockers? A lot of people ask this because they're on beta blockers for their blood pressure. Again, if you have hypertension alone, they're not first-line medications, but they can be if you have other coexisting conditions such as congestive heart failure, you've had a history of heart attack, you have coronary artery disease, you have atrial fibrillation, because they can help, they're a little bit cardioprotective. Examples of these would be metoprolol, carvedilol, atenolol, labetalol. Labetalol actually is one of the preferred medications for hypertension if you happen to be pregnant. It's something to keep in mind. Side effects, they do work also by decreasing your heart rate. That's why we use them in atrial fibrillation. And you can sometimes have orthostatic hypotension while taking them, or a drop in your blood pressure with change in position or standing. So if you stand quickly, feel lightheaded, that might be a side effect of this medication. I will also just say, typically you get a little bit better blood pressure control with like carvedilol over the metoprolol, as this also has some alpha receptor blockade. Other medications you may have heard of or be on: hydralazine, clonidine, doxazocin or terazosin. Methyl-dopa is also good for pregnancy as well. I won't really talk about those, but just to mention them. Alternative therapies, these are to be used in conjunction with whatever treatment regimen you agree upon with your physician. And I'm by no means an expert. And there's not a ton of research. A lot of this is just anecdotal information from patients and people who find benefit. Things like yoga, meditation can help. There's a little bit more research to show that yoga, meditation, deep breathing can help. Some people try acupuncture or essential oils. Like I said, I don't have a lot of experience with that in particular, but if you find that it helps you and you talk about it with your physician and you come to like an agreement on whatever your treatment regimen is, I think that can be fine if you see benefit from it. So the main takeaways are that everyone should be getting screened, and this is done just at your regular doctor's appointments when we check your blood pressure. If you do have hypertension, keep a log at home. I didn't mention this earlier, but ideally, I like my patients to be checking their blood pressure at home and bring that log in with them when I see them so we can talk about it and kind of see how your blood pressures are doing, because then I have a better idea of how we need to adjust your medications if needed. Additionally, if you're checking your blood pressure at home with a blood pressure cuff that you have at home, I always like my patients to bring that in as well so we can compare it to the measurements we get in the office, and just to make sure that it's accurate and doesn't need recalibration. Or sometimes patients' home monitors after a while will start measuring their blood pressures really high, so we don't want to be making changes based on that. So just to make sure that everything is kind of the same. Diet and exercise can have a big impact on your blood pressure. So even if you're on medication, it's still something that you should incorporate into your treatment regimen and your routine, because as we talked about, that alone can decrease your blood pressure. And maybe, if you're diligent with it and it does decrease your blood pressure, you may be able to get off a medication or two. And then, of course, you always want to partner with your physician when discussing lifestyle changes, medications, and come to a decision together about what the best course of treatment is for you. Okay, and then these are my references and then questions.
Thanks, Dr. Potini. If anybody has any questions, if there's we have microphones set up on each side here. There's one here where I am and one on the other side over there. Please just line up and we'll get to your questions. Thank you.
I have a comment first and then a question. The comment is, it strikes me that you have pointed out that high sodium diets are a problem. I know that they're a problem. I worked in a dialysis center for a good while, and at the end of the treatment of 3 hours where a person sat reducing the fluid in their body because their kidneys didn't work, sometimes their blood pressure would be too low, and they would be told to bring in salt or something salty, and immediately it brought the blood pressure up. Mm-hmm. That's my comment. Something that counteracts the sodium is potassium, mm-hmm. which is another thing that you didn't mention. Bananas, tomatoes, almonds, but salt is a huge issue. Also goes along with what you're saying about determinants of people, low income, people who shop in places that are save them a lot of money. Most of the stuff there is very high sodium. Mm-hmm. So, and I don't think that a lot of people know that, and it's a huge issue as far as I'm concerned. The question I have is, I'd like you to talk about the difference of systolic versus diastolic, because sometimes you don't have 120 over 80, you might have 140 over 76. Mm-hmm. And I'm curious about what you have to say about that, and then I'll stop.
You mean in terms of the difference between the top and the bottom number?
Right,
like how large the gap
and what those numbers mean to us.
Sure. I will just touch on your comments briefly. So again, this is more into like pathophysiology and stuff, but typically disorders of salt or sodium are actually water imbalances, so that might be related to the things you saw at dialysis. And it was on the chart that I showed, but yes, higher potassium intake can help your blood pressure, typically reduce it about 4 to 5 points. So in terms of systolic versus diastolic pressure, as I said, systolic pressures, the pressure in your arteries when your heart's pumping or beating, and then diastolic pressure is that pressure when the heart's relaxing. A lot of times, most people typically will see high systolic pressures. We can have isolated high diastolic pressures. There are a few things that you would want to check for in those cases. Sometimes thyroid dysfunction can lead to higher diastolic levels. Some people say that can be more related to issues in your kidneys, can raise your diastolic pressures more. So there's that piece. In terms of the gap between systolic and diastolic pressures, we call that the mean arterial pressure. And we don't like that, pressure gradient to be too wide, but without going into a lot of physics and pathophysiology, that's pretty much it. It's not something, if your systolic pressure was, 140 and your diastolic was 50, I would be concerned. But if it's, 130 over 70s, there's room for variation in terms of the normal, but you don't want that gap to be too wide, if that answers your question.
You recommend keeping a log. Can you give us some guidance, daily, weekly?
So the guidelines state, especially when it comes to when we're diagnosing hypertension, so say you come in, you have a high blood pressure reading, and I say, okay, I want you to check your blood pressure at home for 2 weeks and come back and we'll review the logs. The guidelines state you should be checking your blood pressure in the morning and the evening when it comes to diagnosis. And then we kind of look at the averages to see what your blood pressure is. In terms of, you've had hypertension for a long time and you just keep track, I would just say like a couple times a week would be fine. Yeah.
I have a very related question to that.
Sure.
I actually do have one of those, I think it's Omron, the little home cuff that I got in Walgreens.
Uh-huh.
And I do check my blood pressure, not every day, but at least a couple times a week. But I noticed that it varies a lot. I mean, I'm usually in the 120s, which is okay, I guess. But I've seen it down, in the 1-teens, and I've seen it up like 134 a couple of times. So is that normal to be fluctuating like that? Or?
It is normal, and the first thing, of course, you want to do is make sure you're taking it appropriately, sitting, feet flat on the floor, all those things we talked about. The other thing, too, I did not mention is wrist cuffs tend to be less accurate than the arm cuffs. And also, taking your blood pressure multiple times in the same arm can alter the measurement as well. But in terms of fluctuation, yes, that's normal because maybe you had a little bit more salt today or a little bit stressed or, whatever it is. That's why when you bring your logs in, we kind of look at the trends and the averages as opposed to one isolated reading. Unless it was like, 200 over 120, then of course I would be concerned. Does that answer your question?
Sure, I guess.
Okay.
I mean, some of those in your chart that had the normal versus elevated versus,
Right.
I mean, that was a fairly narrow range, and I'll see myself in all three of those ranges.
Yeah, it is. Well, that's why with the diagnosis, we want to look at kind of the averages that you've been, so if you're measuring at home, we want to look at the average of your blood pressure over like that 2-week period to see on average, you're in that hypertensive range, or on average, you're actually okay. You maybe had 1 or 2 isolated high readings. That's why, it's not necessarily strict, there is the art of medicine, and we use evidence to help guide us. But I wouldn't be too concerned. Based on what you're telling me, it sounds like that's fine. I wouldn't be concerned. Okay. Yes.
On the DASH diet, it listed low-fat dairy, and I'm plant-based. Are you saying that dairy's beneficial to us, or if we're going to have dairy, it should be low-fat dairy?
If you're going to have dairy, it should be low-fat dairy. You can also use like dairy alternatives, like almond milks, things like that.
So basically, you're saying have less fat, not necessarily eat dairy.
Correct.
Okay. Thank
Or,
you.
and some people might follow like the Mediterranean diet. It's like they're similar in terms of their recommendations. And you can, Google DASH diet and it'll give you a whole list of like meal plans, all this stuff, just as like guidelines to follow.
Thank you, Dr. Potini. We have an online question, and that is, are there particular vitamins that will help with lowering blood pressure?
Not that I'm aware of at this point in time. I did try to find certain supplements that people recommend for lowering blood pressure. There's not certain ones that I'm necessarily aware of at this moment in time. If people come up with things, people should bring me items to my office and I'm unfamiliar with them, I'll try and look up whatever research is available on those particular items. So I don't know of anything specific at this time.
When you're taking your own blood pressure, is it necessary to have a bare arm? And how tight should you make the cuff?
So yes, we get the best blood pressure measurement when there's nothing between the cuff and your arm. So you would want to, not have your shirt or anything in the way. And you don't want the cuff to be too tight before you start measuring it, just snug at the level of your heart. And typically a lot of the cuffs will have like little markers or indicators for how to position them.
You should take the blood pressure twice a day. May I ask you when, what time? Before the meal or after the meal?
Yeah, so
The second question is before the exercise or after the exercise?
So that twice a day is especially more for like diagnosis, but try to take it at least 30 minutes to an hour after. So if you're going to exercise, don't take your blood pressure for at least 30 minutes to an hour afterwards. A lot of people will wake up in the morning and check their blood pressure. That's fine. That's I think a perfectly reasonable time to do it before really getting active for the day. And then, before bed, an hour or two before bed, whenever is convenient to you. If you're going to be really active and activated during the day, that might not be the best time to take it. But if you're going to exercise, wait at least 30 minutes to an hour before checking it.
So before the breakfast is better or after the breakfast?
Whatever is convenient to you. I don't think eating will really have too much effect on it. But like I said, a lot of people will wake up and check their blood pressure like first thing in the morning.
Thank you.
Hello. So I have an exercise-related question as well, since that was a couple of the things on your chart. Can you say what the expected effects on your blood pressure are after you've been exercising? So, assuming you wait an hour or an hour and a half or later the same day, if you've done 2 or 3 hours exercise, what would you expect to happen? Is there a rule of thumb in terms of the systolic and diastolic?
That same day, after several hours, you may see a slight decrease, but you're really only going to see the types of long-lasting effects with continual exercise. So I think what you're asking is, today...
It was really related to, the body trying to recover from the impact of exercise. So for example, if I go cycling for 3 or 4 hours, later that day and the next day, I'll ache, right? I hurt. So the question is, my body's trying to recover. What would you expect to see on the, with the blood pressure numbers?
I think, and immediately afterwards, we would see some increase in blood pressure, but once you are fully recovered, your heart rates come down, all that kind of things, we may see a slight decrease in the blood pressure. But again, that's only going to be transient. We won't see significant, long-lasting effects unless it's regular exercise. Does that answer your question?
Yeah, more or less. I was just wondering, if you're exercising 3 or 4 times a week, the next morning each time, if you take, I feel tired, your muscles ache, is it reasonable to see, one or the other number up higher than if you took a week off and just did the same measurement?
So actually, you probably would see higher blood pressures if you take like a week off exercise. You might see your blood pressure go up a little bit. Does that answer it? Okay.
With medications, like the calcium channel blocker, when I tried that, I found I was very drowsy the next day. How long do you stay on a medication to see if those sort of side effects will clear? Or if you have it after a few days, that's kind of how you're going to process it?
Well, so the first point is with medications, you could be on a medication for years and then all of a sudden start having a side effect. We can see that a lot of times actually with cough and ACE inhibitors. You've been on it for years and then you start developing this cough and then we take you off of it and it goes away. So your question is how long to be on the medication with the side effect before
you're-
seeing if it'll get better?
Yeah, if you're trying a medication and initially you get real drowsy with it, does that tend to wear off in a few weeks, like stay with it? Or if you're going to get drowsy and it's not tolerable, it's pretty much the way it's going to be?
You know, I think if you have a side effect that is significantly bothersome to you, it's worth mentioning and trying a different medication. If it's something that you're thinking maybe it's related to the medication, maybe not, maybe try it out for a week or two. But again, that's something you would discuss with your doctor to see kind of, you know, what their thoughts are as well. Other things too are how common that side effect is with the medication and things like that.
Okay, thank you.
Yeah, on the 120/80 nominal, is there a bias or rule of thumb that you apply if you're over 75? Since you said it's age, it increases with age.
Right, so the sprint trial, which I mentioned, doesn't specifically give any guideline, but typically I would allow for some leeway because there are the risks of low blood pressure as well. So I would probably, you know, over 75, if you're in that like 120 to 130 range, that's, for me, that's fine.
Yeah, if you're 130 over 85, what would you recommend?
I mean, it kind of depends on everything else going on. Like, do you have any other medical conditions? How functional are you? Those types of things.
Okay.
You know, like, really, what do we think your life expectancy is moving forward? Do we think that based on how functional and healthy you are, you'll probably still be here in 15, 20 years? That might be different than if you have a lot of other medical conditions and functional status is poor.
Okay, so you take individual issues
Yeah,
into effect?
I think it really just depends.
Okay, so stay with the 120/80 roughly.
Yeah.
Okay, thank you.
Okay, one more question from an online viewer, and that is, how does resting pulse factor into this conversation?
So how does your pulse affect your blood pressure?
Resting pulse was the question.
So I guess what I would say is your resting pulse rate is not on any medications or anything, is probably an indicator of your overall health status. So I don't necessarily think they're directly correlated, but if you have, you know, a healthy resting heart rate, you likely will have better blood pressures. But I haven't seen anything in the literature, at least in my search, that shows lower resting heart rates mean better blood pressure. I mean, there's probably an anecdotal correlation there.
So does anybody else have any questions I can bring? You do. Thank you.
I've been trying to find out what actually causes high blood pressure. Is it your veins are clogged and makes your heart pump harder? Is your heart pumping too hard? What actually is the physiological thing?
So yeah, so we don't know 100%. That like essential hypertension. It's just really the modifiable risk factors and the non-modifiable risk factors. I would, you know, like I was saying, your mean arterial pressure is your cardiac output times your peripheral vascular resistance. So how much blood your heart is pumping out versus times the elasticity in your peripheral arteries, the small muscular arteries. What causes like changes in the elasticity versus, you know, changes in your cardiac output is basically those risk factors I showed, but it's not there's not, one specific like pathophysiological route that we know of that causes it. So it's really just those risk factors and knowing how to calculate the pressure.
Okay.
Okay, we got one more question, I think.
I didn't hear anything about caffeine usage.
So yeah, there's actually, the evidence doesn't really show any like effect, like specific direct effect from caffeine on blood pressure. But some, you know, some people feel like it affects their blood pressure, some don't. So I can't really give like a great recommendation because there's just not the evidence there.
Thank you.
Okay, if you can all join me in thanking Dr. Potini for sharing her expertise. Thank you.